is Rick Wickstrom with Workability Systems, and today's presentation will be about a different approach to functional capacity evaluations, where we'll actually take the evaluation to the worksite as a way of creating more efficiencies and better communications between the employer, the worker, and the clinician. A little bit of background about myself. I'm a doctor of physical therapy. I did a transitional DPT program and then also during my graduate school work in ergonomics, I became a certified professional ergonomist, and along that same kind of career path, I became a certified medical examiner to do DOT physical exams, first in Ohio and then in Kentucky. And I'm just coming off 6 years of service as the Occupational Health Special Interest Group President in APTA Orthopedic. My practice in a nutshell really is fitness for duty from hire to retire. So it's looking at issues of safety, musculoskeletal health, well-being, and productivity. I do have some things to disclose. As the owner of Workability Systems, I do teach physical therapists and occupational therapists and other types of practitioners about doing advanced functional capacity evaluations. And then also I've been very involved in the development of software products and tools to that support occupational health in various ways. The main objective for this presentation is to describe my role as a physical therapist in ergonomic consulting in providing direct contract occupational health services to both employers and vocational rehab agencies. And that's an emerging area of interest by many in our profession because they're tired of dealing with traditional insurance types of reimbursements. And I don't take traditional insurance reimbursement through my practice, except for the Ohio Bureau of Workers' Compensation and rehab technology service contract with our Opportunities for Ohioans with Disabilities, which is another state agency. I'll be explaining a kind of a strategic approach to doing a worksite functional capacity evaluation as a way of facilitating job retention and accommodation using assistive technology and ergonomic equipment. So one of the things in my practice that's been successful when we do go to the worksite, oftentimes we have an opportunity to bring the job demands down, as you noted in the prior presentation. If you can bring the job demands down, it makes the work task more accessible to a broader and more diverse range of population. And essentially, it's a paid marketing call for your clinic because you're creating a presence for physical therapists that when someone else has a problem, they consider you as a potential resource. Now, I don't believe that you can just operate out of a clinic-based model to really be effective in ergonomics, especially when you're dealing with disability kinds of issues. And I've been in private practice physical therapist since 1989, so it probably dates me a little bit compared to the two of the earlier presenters. And a big focus of my practice and also my advocacy within the American Physical Therapy Services is to improve access to physical therapists as entry point occupational health practitioners for services that range from activity, participation, wellness, musculoskeletal health, and disability determination. And there's actually a position statement that you can search for at apta.org that I co-led with James Spencer in the Orthopedic Academy to explain why that's an important area for us to emphasize as a profession. I do have an outpatient clinic that's located in Westchester, Ohio, but quite frankly, most of my work, when I do true rehabilitation work, is either going to a fitness facility such as Planet Fitness or going to the worksite and transitioning people back to their full range of duties. So where in our workers' compensation system, it's not unusual to see people get 30 visits of outpatient physical therapy. Oftentimes when I go to the worksite, the average number of visits to get someone from even a fairly acute injury back to work is probably around 6 visits. I do mobile functional capacity evaluations through the PT Compact regulations and ergonomic consultations throughout Ohio, Kentucky, and Indiana, since I'm in that tri-state area. So this is the tri-state area where I operate from. Ohio is my main base, but I do travel to Indiana and Kentucky to do specific consultations. And Ohio is a very unique state. It's a monopolistic state for workers' compensation. And by that, it means that basically the state is the primary insurer of the smaller employers for workers' compensation. Other private insurance companies can't insure smaller employers. The larger ones do have self-insurance programs, and that's and through this monopolistic program, I've actually been successful in collaborating with the state to authorize codes, special codes that pay physical therapists quite well to go to the worksite. And they pay not only to get to the worksite, to do things like workplace therapy and ergonomic studies and functional job analysis, but they also pay some travel time and some mileage because that can be a factor to encourage people to get out of the clinic and go to the worksite. As I mentioned, two of the states, Ohio and Kentucky, are I was the first physical therapist to become a certified medical examiner in those two states. Kentucky had ruled against it, and it took almost a year to get them to educate them in the other direction. And believe me, Indiana, since it's part of my PT Compact licensure, is squarely in Rick's radar. This is an adaptation of a favorite slide that I've seen by a couple of different folks, but Jennifer Christensen is in particular, where it really communicates the kind of the gap or the chasm that exists between a clinic-based care model where you've got doctor restrictions and doctors that are largely uninformed about the real workplace demands and oftentimes making arbitrary decisions about work restrictions. And then you have workplace demands, which is the practical side of things where, you know, productivity is king. Employers have job functions that need to get done, and they don't always understand the physical complaints of workers. And a lot of times if you have a supervisor that's been through a work-related injury themselves, then oftentimes they're a better individual to work with the worker and make accommodations. But it really is a broken system. And if we had programs in place like the one at Work Healthy, South Carolina, you would have a better foundation for expediting early return to work, and you wouldn't get into such a dysfunctional disability kind of thing that really was the reason why I was involved with this particular case. So I think of this as best practice playbooks. I love that Brent Weber spoke about that we're selling solutions. We're not selling products. We might have a product that we use to do a solution, but we're really selling a solution to a problem. So this is the there's the safety side that Brent spoke about. There is with the injury prevention model. There's the kind of the wellness side that Kelly was kind of getting into. But when you get into health solutions or disability management, in my mind, the solutions are having a really good foundation in terms of a transitional work program, policies and procedures, having a well-established musculoskeletal primary care model set up so that physical therapists are providing short-form FCEs as regular treatment updates to prescriptions during that care process, and actually getting out of the clinic and going to the worksite to validate the job demands. And I do a lot of work via telehealth, where you can literally, if you think about some workplaces like coal mines, for example, I'd have to train for a couple of weeks before they'll even let me down into the coal mine. But if you have a telehealth kind of model, you can actually interface with the safety manager, have them take a walking tour of the facility, show you the representative job duties, weigh an occasional item here or there, and even capture some video and save it in such a way that it can play as part of a report, a PDF file when you click on a hyperlink. So I'm going to talk about functional capacity evaluations, but I'm going to really talk about a different way to approach them where the person still has a job. They're not just applying for disability benefits. And some of my heroes in functional capacity evaluation, Steve Allison, who led the 2018 practice guideline version, and I've collaborated with Steve on so many different projects, and Jill Galper, who co-wrote an AMA guide on functional capacity evaluation, and David Hoyle, who's now is now vice president of Occupational Health SIG, and even Jim Meacham, who's an occupational therapist and very involved in this space. And so this guideline is our most recent guideline. I was fortunate with Gwen Simons to lead the 2011 guideline. So this is one of my sources, the clinical guidance to optimize work participation, our CPG, that we developed and published. And there's two key areas of statements that I've listed here for job demands and for physical performance measures that are very relevant to how to approach the presentation. And what and to kind of bring it home, when I took over as the president of the Occupational Health SIG about 6 years ago, our vision was to establish an implementation resource that would really draw attention and really prompt people to use and implement the clinical practice guideline and current concepts work that we were doing. So these are the 3 steps, and I'm so grateful that managers like Brent Weber have really embraced using our program as a foundational piece of the training and onboarding process with their staff. Within this program, in the first Bridging the Gap series, and I expect when we update this, it'll blow up twice the size, but there's a couple of key, one of the key elements is the functional job analysis and job fitness exams monograph that's in here that was led by Mo Tillery, and I was fortunate to be one of the contributing authors to that. And in the advanced program, there's a functional capacity and disability determination module that was led by Wayne McMasters, and Steve Allison and I both contributed to that monograph as well. And I love being a mentor for people that are participating in the 3rd phase of the program. It was such a privilege to interact with Brent and to learn more things about really much more upstream than any of the work that I had previously done with employers in terms of that early intervention injury prevention model. So I'm going to tell you about a real unusual case that landed on my lap, and oftentimes I'll get these quirky cases that occupational medicine clinics and whatnot just don't know what to do with. But this particular fellow was born with congenital heart disease, and back when COVID struck, had the unfortunate experience of having like a major stroke. I mean, this is a massive stroke that affected him. And then after he recovered from the stroke, he got a full-time job in a parts department. This is out kind of like, in a fairly rural area of Ohio, but didn't really perform well from a safety and productivity standpoint. And so he was let go. And then he got a part-time job as a retail cashier. And we've all seen these kinds of building products companies where they're using hand scanners and not having to lift the materials as much. But, again, I think he had some issues with productivity. And so the employer basically just start turning his number of hours down from 26 per week to 5 hours per week until he quit that job. And then he got a new job in a parts department for a farm, like a tractor kind of equipment service supply company. And he told the employer coming into that job that his disability was actually very temporary, and that he was going to completely recover within the next year. And after about a year, the employer decided to put this worker on a leave of absence after he had a work-related fall, and just became the bathtub kind of overflowed with the employer, and that's when our state agency pulled me into the picture and asked me to perform a Worksite FCE to see if we could basically salvage or support his return to work. Now, one of the challenges in this process is when the employer human resource department sent questions to the doctor. These are ADA kind of questions. How do the limits affect his ability to perform the job? The answers they got back from this particular physiatrist were more like information that's given by like a school age IEP kind of program. They were very general and didn't really provide the employer with concrete answers for how to deal with his situation. And there's Peppers et al. Did a pretty good article with the VA hospital and physiatrists and how quickly that they how low when you ask them to estimate the person's abilities, that you can generally, if they send up for a functional capacity evaluation, it generally upgrades, it influences the physiatrist to increase their restrictions by like almost twice as much, going from like a light level of ability to a medium level ability. And that's by doing performance-based testing. So part of my job was to kind of dissect the employer concerns, things like the worker kind of wandering through areas that they perceive to be a safety issue for him because he's in proximity to forklift use, his slow productivity with doing his tasks, his unrealistic expectations that he presented initially. And then, of course, some very reasonable requests by the worker to remove things that he wasn't seeing particularly well because of some of his visual blind spots and some difficulties going up and down the stairwell where there's only a rail on one side. So there's some pretty good data that shows that that our Equal Employment Opportunity Commission really expects employers to have comprehensive policies that deter disability discrimination. And that there's case law. This EEOC versus Red Barchetta is a classic case, and I've got all these where they're numbered and listed in the back of my report. There's a reference list with hyperlinks, and I'm happy to share my a handout if any of you are interested in seeing some of these particular references. But some of the red flags that justify job-specific FCEs, in my mind, are when people are off work like to the full extent of like a disability policy, and all of a sudden God happens and they become healed overnight, and they get released they go from being completely unable to completely full duty, all in one 24-hour period. And I haven't seen that kind of thing actually happen in real life, but it seems to happen a lot with abuse of disability benefit systems. Also, we see situations where people are restricted to a very high level in their work activities, but then they're observed doing inconsistent activities during their daily activities. Or we now have data that shows for a given condition what the expected disability determination is, and that's probably one of the reasons why like business owners that have carpal tunnel surgery and are returned to sedentary jobs are expected to generally get back to work within about 3 to 5 business days, but that doesn't happen in the workers' compensation system. There seems to be a fair amount of latitude there. So our process in doing a job-specific functional capacity evaluation involves starting with the job as the first part of the workplace visit, understanding the job, understanding the barriers from the worker's perspective, from the supervisor's perspective, and then also making sure that you're getting one version of the job demands. Because if you talk to the supervisor separately or the worker talks to the doctor separately, you're going to get 2 versions oftentimes of what the job expectations are, depending on what the circumstances are for either the supervisor or the worker. So surveying them in some manner, we call that participatory ergonomics, really drilling down on the most physical job demands or the peak job demands. And then when we develop functional job descriptions, we also look for transitional work options that would keep someone in a state work model rather than going off work and coming back to work for the most common patterns of restrictions. So we look for one-handed banded jobs. We look for primarily sit-down jobs. We look for light lifting kinds of jobs that you could immediately give to someone that's complaining of musculoskeletal conditions before they separate from work. And then using that information to design a job-specific exam. I'm sure with the case that Brent presented on the basal load, then there'd be some kind of overhead lift, to a certain cut score that related to the weight of maybe the heaviest loads that have to be handled. But we always, in creating that exam, whether it's a post-offer job fitness screen or a job-specific FCE, we tend to start most of our exams with some form of musculoskeletal quick tests of movement screen, and then also try to look for things that are easy to set cut scores for when measuring performance. And then part of that process is to think about that as an opportunity to improve job performance and improve healthy physical activity patterns. So it's a real total worker health opportunity for the worker. And it's really an intervention opportunity when it's presented in this context. But we don't want to return broken workers to broken jobs. It's not acceptable to just develop a job fitness screening program for a hazardous job. We have to be very interactive and encouraging in that regard. And on the other hand, we have people entering the workforce that have all kinds of work conditions, and many times we don't even know what they are because employers just are not screening people properly and catching those things, or the people that are doing the screening are focusing on health history issues instead of really being performance-based. So part of our process is just to say, and I've had the opportunity during my time, even in the Occupational Health Special Interest Group, to actually serve as a representative to the Bureau of Labor Statistics as they developed a new system or occupational taxonomy to replace the Dictionary of Occupational Titles. Dictionary of Occupational Titles was last updated in 1993, which is over 30 years ago, but actually many of the updates were done in the 80s. So the world of work has changed a lot since the 80s. And so the DOT was initially replaced, the 14,000 jobs were collapsed into 1,000 occupations in the ONET system. And the ONET did not do a good job with physical demands and environmental conditions. And so this occupational requirements survey approach really has added some better terminology and taxonomy for all of us to consider as we're developing and formatting functional job analyses. And just for example, some small things that we've had some influence as contributors to them is they've slightly retooled the way that the strength factor is done compared to the DOT taxonomy, and now it's based primarily on weight and standing time. They've also inserted a new level of frequency or duration scale called seldom, which really gets at activities that occur less than 10 minutes for the whole day from a duration standpoint. And that helps to flag things that oftentimes can be restructured or reorganized among the work team, because we deal with so many work teams. And the questions from an essential job function standpoint is every member of the work team expected to do that function? Well, not always. I mean, that's one of the reasons why I like when I was working at companies like to create aircraft engines, we had taller workers working on the top part of the engine and shorter females or people working on the bottom part. Now, this is just an example of a different way to present functional job information rather than just present it as only what the job requires, but actually present it in a survey format, so that when you list that factor or that lifting capability and the demand rating and give an example, the worker can help us answer the question yes, no, or are they unsure of whether they can meet that job demand. And so a conversation can be had with the worker to essentially help establish a differential diagnosis of where they're struggling the most in doing the job. And if they're not, and even before they see a healthcare provider who certainly knows a lot less about the job than the worker does. And so that provides an opportunity to an interactive opportunity for the worker and the supervisor to come up with better solutions to kind of work around some of those issues. And I just put a QR code for anybody that is interested in seeing like a full-blown example of this style of presenting job information. Just another way of presenting a report as a tool. And this same report can be sent to the physician that's writing restrictions or the physical therapist that's maybe treating the person in the clinic, so they have a better idea of how to structure a job-specific plan of care and tackle the things that aren't matching up. So I want to give you kind of a visual for this worker. And as you can probably guess, his stroke side is not the right side. He's reaching on the right side in a very normal way. But if you look at, just like in the truck examples, when you're unloading a truck, space is at a premium. And this is a parts place. And what he's doing is he's building kits. He's picking the parts to build a kit for certain kinds of engine, tractor engine and other kinds of repairs. And he's working off of kind of an older dandy lift style of cart that has a pump up hydraulic type of thing. And one of this young man's challenges is he's a really slow walker. As I had him demonstrating his activity and what his job was to me, it was obvious he was leaving that cart in the middle of the area and he was walking to all these areas and walking back. So he was adding additional walk time to all of his activities, which and he couldn't walk as quickly when he wasn't holding on to something. So in a way, a cart can be like an assistive device. This shows, and the main reason on the left-hand side, I'm showing that little stool, but you can see that little footstool that is available for his use. But, we always want 3 points of control, even when you're stepping up and down from a two-step ladder. And so I just show an example of maybe a better developed Little Giant style of step tool that has an actual built-in handle where he can, when he gets to the top step to reach that top shelf, so we can actually see what he's picking from. He can brace his thighs against that for stability and also use it as a point of stability when stepping up and down. So, no employer can tell you how to lift something. And so, he's right here, he's basically taking the item that he picked on that cart and he's picking it up and putting it into a fixed height workbench, okay? And so he can't really grasp with the left hand, but he's able to use it kind of like press against it with the side of his forearm. So he can handle a certain amount of weight using that method. And then on the right side, you see him where those items have to be stored at different heights, but they're higher heights than the cart will go up to. So my brain is kind of thinking about things that are like office work positioners. Like this is a global tool. It's an office work positioner, but it's got a little battery on it. So you push the button and it goes up and down. And where this young man had the most difficulty is in the lower zone, but it lowers down so low that he can kind of manipulate the item too without actually having to pick it up to put it on the cart. And it goes to a pretty high capacity to meet that length. So I'm just as he's showing me with his activities, my brain is just going on, well, what are tools that we put together to that work well, like that fixed height workbench? The height adjustable tables have gotten way less expensive, and they have a fair amount of latitude as far as low to high kind of range. And this is where he was having some difficulty getting the items to and from his little cart. And by just adjusting the workstation up and down, it becomes a simple push or pull slides. I mean, I hardly ever find that push and pull forces are really the limiting factor. It's usually the lifting up and down forces that are. And this is his little cubby station where he's building little marketing kits and things like that and expected to use the computer. And he has, as you'll see from the exam part of it that we did, someone that is just completely only able to use one hand for dexterity activities. There are some pretty cool tools out there for doing one-handed typing, but you've got to be pretty, it's dramatic change in learning how to type in a completely different way. And not everybody takes to these kinds of things, but this is a very good tool that's made overseas. And it's a little bit pricey, but if it matches the right person and gets them more productive, that's a good thing. This is the issue where the worker was saying, like, you can see when you go up to this mezzanine, you can see where there's a rail for him to hold on the left side with his hand. But if he was to come down that same set of stairs, there wouldn't be a rail for him to stabilize with. But interestingly enough, on the other side of the mezzanine, there's a similar, what he wanted was a rail on both sides. That was his request. And but as we reviewed that activity with the employer actually made it very clear this was a marginal task, and he doesn't really even want this individual going up and down to do anything because of security concerns. But there's definitely that was a reasonable thing for him to say, hey, I'd like to have something stable to hold on to when I'm going down a set of steps. It's not as unforgiving to go up a set of steps, but you can imagine getting something, coming down with it, maybe having something under your hand or in a basket, wanting to have 3 points of control. So this just gives you kind of a flair for how we communicate functional job analyses with our ErgoFit platform. We're not trying to rewrite the human resource job description. We're trying to describe the functional flow. We can create optional fields, narrative fields with it. My three go-to narrative fields for it are the functional work process, whatever that is, depending on how complex the job is. What are the typical tools and equipment that are being used? And then I try to put some type of work sample fitness test in there that would give an outpatient physical therapist an idea of if I wanted to test the person's ability or readiness to come back to work. And this was like, got to be able to lift 15 pounds. That was the approximate weight of the kit from ground to overhead to do that job. Work schedule restrictions are very common. We've got factors that relate to usual schedule and maximum shift schedules. And you have a rating area, but you can put as much comments as you want to under that rating area to clarify that better. Materials handling, we follow the ONET frequency range for constant versus frequent versus occasional, but we split the seldom lifts into carries, high lifts, low lifts, and middle lifts. And you can always describe that in more detail for within those categories. These are just a few of the postural tolerance kinds of things. And one of the unique things about ONET, like for fine manipulation, for example, is you rate the degree that it's required for the whole job, but then you also determine whether it can be done with like one hand or both hands as well. And same thing with firm grasping and some other factors. This is a new section for functional job analyses that is a set of 10 factors that is really, in a way, it's describing types of severe disabilities that could potentially do this job. This individual did that job for a year, and so the yes here means that it is self-paced. It can be done right next to a small cart, as long as you're not walking away and coming back in. It couldn't be done with someone that has profound cognitive difficulty. The work schedule wasn't that flexible. There was a fair amount of interaction in that job because of his marketing functions, so that's why it's no. It could be, the items could be picked using primarily one-handed manipulation. Some of these factors you may relate to the American Community Survey that looks at things like profound hearing and vision and other things like that, but it's expanding. A person couldn't do this job if they were teleworking from home. They could do it if they had speech difficulty and used alternative communication ways. This really is just a modified table from our step 2 course on functional capacity evaluation, and just lists some different movement screen options that are out there. And I was the pioneer in the active movement scale. We started out with 14 movements and basically skinnied it down now to 8 fundamental movements. And those 8 movements are kind of presented on this slide here. And the rating category, these movements are all scored based on the person's ability. So if they refuse to do the task, it would be a 0 points. If they did it some of the way, partly did it, then it would be poor. If they did it most of the way, then, or with only minor deficits, that would be 2 points. And if they did through a full movement performance, it would be 3 points. And so that scoring is applied to each of these 8 fundamental movements, and then those movements are combined to come up with a total body risk score, a lower body risk score, an upper body and right arm score. And so this is I can do this movement screen in 2 minutes flat. It doesn't require any special equipment. We generally will sit the person down to do the upper extremity movements, so that people like the individual I saw last week that was paraplegic could demonstrate fairly normal performance for all the upper tasks, but we had to be 0 rate them for all the lower tasks. This just gives you a sense for when you take them through a movement screen, like opening the hands on the left-hand side, the right hand is behaving in a normal way. The left hand is just not keeping up with the right-hand side. And when he makes a grasp, he can grasp with the left hand, but he's really not able to functionally use that hand. This normal movement for the wrist extension is with the hands together and they drop into an extension. But in his case, he had so much flexor tone in his hand from the stroke that I had to have him use his forearm to demonstrate that he had basically normal flexibility in his other arm. This is a classic example of elevate shoulders, and completely normal performance, more than 180 degrees on the right-hand side. But this is the best. He couldn't, one, straighten the arm, and two, he drops into that flexion pattern and can't elevate it above shoulders, so he gets 0 rated on this one. His actual head movements are just slightly restricted. I don't know if you have the keen eye I have from doing so many of these exams, but he's a little bit stuffed going to the left side, where he's got normal performance to the right on rotation, and has pretty normal head extension. This is a forward bend over movement, and which requires some balance, but he's also got lower extremity tone issues that impact his ability to do basically a toe touch style of reach. And so he's and then here on the rotation, you can kind of see most people can keep their feet in place and rotate 90 degrees to either side. And he's got limitations in both directions. And some of that is a combination of balance and lower extremity tightness. Interestingly here, the deep squat, he was able to drop into a deep squat. He was actually able to stand on his unaffected leg for 6 seconds on a single leg stance as well. I just didn't display it. But on this lunge, even though his stroke is primarily affecting his left side, he actually does a better lunge down with his left knee than his right knee. And it just goes to show you just don't know until you actually put people into these positions how they'll do. And this is how the report is presented on like what I call a data snippet, because we've set up in our Ergo, in our ExamFit platform, we've basically standardized how the tests present for each test, and then we make it easy for the provider to mix and match any combination of tests they want to generate a report that follows some pretty standard analysis and reporting. But we have the 8 movements, they're all rated, and then they're combined, and then some of the movements combined that relate to the neck and the shoulder to look at that. I was dealing with a small space with there, and so I have a really simple test called 2-square agility test that I published a paper on reliability and validity on it. We use for grip strength, we're using the Wang normative studies that are published in the Journal of Orthopedic and Sports Medicine in 2018. For hand coordination, one of our go-to tests is a keyboarding test, because if you can't type well, you don't have a lot of options when you have profound disabilities. Like the groove pegboard test a lot, and we have another test called the workability rated manipulation test that is a more efficient version of the Minnesota manual dexterity, but in this case, he had no prehension with his left hand whatsoever, and he had completely normal function in the right. And again, this wasn't the type of FC that we're doing to determine whether disability benefits are appropriate. This guy wanted to keep his job. He was hanging on to his job for dear life, so I didn't have to do a performance validity assessment with him. He was demonstrating by his very interactive behavior and actions and everything that he wanted to keep this job, and he was being kind of nudged out by his employer at that point. This just shows a couple different ways. Like when you go to Worksite, you can't take a fancy shelf with you. So I use painter's tape on the wall to set, like for a high lift, I'll set the painter's tape at head level. And but this young man, because of his shoulder problems, he could still do a high lift, but he had to lift it more like a waiter that's going through a crowd, and he handled 15 pounds, which is what he had to do to get some of the parts up to that shelf. But it was all with the one-handed lift. And this where he struggled the most was with the lower lift here, trying to get underneath a pan. He's trying to stabilize that and get under with his hand. And this is where that office tool positioning device would allow him to manipulate it to that and then push a button to get it up to a better height where he can handle it better. So I've got I've got some different, I just put a couple of data snippets just so you see how we present information on high lift and other lift tests. And it's very common when I do exams in the workplace or in the clinic to actually take pictures of people doing the activities so that the person can relate to the person more so than to the just the text data that's describing that person. And part of that, reviewing those lifts is to know like what a RPE exertion is for that type of lift and at different loads. And I'm just putting up a couple of I've had the opportunity to work with Dr. Robert Robertson, who invented the Omni Exertion Scale, to make his scales more generic. And I use these scales as an ergonomist to not just rate like lifting activities with the workers doing, but also to rate any kind of task that the worker's doing in the work site. The one on the left is we've got thousands of them printed up, and if you like them and you want to order a supply, we can get you wired up through the Occupational Health SIG, because we branded it with the Occupational Health SIG. And then the one on the right is one that I'm engaged in research right now with a study that involves kids and their parents doing a combination of gripping and stepping endurance tasks. When you complete this type of analysis, you're faced with a job match kind of thing. So you select a series of factors, and I put check marks in. Well, where's this worker matching up with the job? And where he had the most difficulties was with that high and low lifting ability, and then also his walking speed, which needed some interventions or some tools. So whenever you do a job match kind of thing, there are things that don't fall within the factors that you pick, and they're kind of unique. But my goal really was to help the employer understand in more layman's terms what he could and couldn't do because of the severity of his injury, in very simplistic language, like, he can't do any fingering, gross manipulations, or gripping tasks with his left arm. He can safely walk at a slow pace, wearing his left AFO to reduce his foot drop, but his gait looks abnormal, but he's not at a risk for falling. As long, and he's able to negotiate steps, as long as there's a grab rail on his right side when he's going up or downstairs. And that he could actually climb a different style of stool on a seldom basis, as long as he's using 3 points of control. And when he's bringing items from higher shelf down to lower shelf, he may need to bring that item down before he starts moving or stepping, move that item down a little bit, and then use 3 points of control to go down to the next step. That he can use his computer, but he's slow, and that he may need to use some type of one-handed keyboarding or voice recognition program. And I mentioned the global industrial one. So these are just some of my references. I tried to include links with each one of these and make sure that we had got more than 5. And then, whoops, next. Sorry, I didn't mean to take you to that document, but then we've got the remaining ones which are some of the references. And I did publish 2 articles this year about the active movement scale that I'm pretty proud of, and also have had the opportunity over the past year to team up with 3Motion AI, which is to actually do 2D, 3D computer vision and develop an app that can be combined with the job risk assessment that, like Brent mentioned, that he's using at Work Healthy, South Carolina. So my reflection is only that we kind of began this journey for the OHP program with the end in sight. I've already qualified for the program with a wellness total worker health topic, but we did have someone that had to reschedule their presentation and left this slot. And I thought, well, gosh, you guys are talking so much about really upfront stuff. Let's talk about the really reactive stuff when you really have a pickle in your hands that you're trying to solve. And with the OHP program now, because of people like Brent that have committed to the program and are sending people through it, we're generating some revenue. We're basically generating revenue that we can use to promote occupational health research. So kind of like one of my last kind of parting things before I turned the reins over to Steve Allison was we created an OHC-SIG research grant for this year. I don't know what will happen in subsequent years. And then we're also beginning to do the work again to kind of re-update our clinical guide CPG guideline. And so there's opportunities for people that are research geeks like I am to get involved and to participate in that. And that's everything. I had to go after Brent, which I knew was going to be a challenge because he can talk, and I don't think I can talk quite as fast as Brent can, but I truly apologize for I, for perhaps slowing you down a bit. And I couldn't meet the 20-minute goal.
Thank you very, very much, Rick. And I think this is great. I'm glad you stepped in to present on the on functional capacity eval. We do need a lot more of those presentations and more of the application pieces. So those are great. Let's open it up for questions. So are there any questions? We can take a couple questions and then move into the last section.
So Rick, I know you touched on it. How did you get the referral for going on site to do that? Is it from the employer or through the state supported insurance?
I got it as a job save referral from a state agency that is charged with basically getting people back to work or supporting individuals with disabilities. So it kind of rose to the point where it the employer was kind of making complaints and it just kept escalating. And yeah, so it was really a job save style. Frankly, when I went into this referral, I didn't know whether it would be a job save or job lose. I was sent in to be an independent arbitrator between the worker and the employer and really clarify, well, what are the needs are and what are the opportunities for if he could continue to do this job. And it was one of the situations where the employer made very significant accommodations, almost like a supportive employment model for the worker for nearly a year. And then it wasn't until he had a little work-related fall that really didn't result in a substantial injury that the employer started, their bathtub kind of overflowed. And we had a worker that was kind of in denial and misrepresenting his abilities too. So it was a very challenging situation to facilitate that interactive experience between the worker and the employer because there were some concerns and hostility both directions.
So do y'all have like a vocational rehab in that
Yes.
state? Is it so? I could see where they might refer as well.
Yes.
Okay.
So in the Bureau of Workers, if the referral came from the Bureau of Workers' Compensation, they pay me quite well to go in and do this kind of stuff. Like an ergonomic study has a special code. It's like almost $190 an hour for that work. You know, and you can compare that to traditional insurance kind of reimbursement. The state rehab agency doesn't pay nearly as high, but the work is so interesting to me that it pays enough to people that I do that work with, and I do like home mobility. I do a lot of work from home office kind of things, and both agencies send me all over the state to do like home mobility kinds of evaluations, and sometimes I have to do them virtually because of travel constraints and other things along those lines. But it's possible to do some of this work virtually, especially work from home office kinds of setups. You know, not necessarily a job like this where you have to literally weigh and measure things for the employer.
And I don't have another question, but just a comment about early on, you talked about the gap between the doctor's restrictions and the workplace demands. You know, I've told a lot of people over the years, like if doctors were good at writing restrictions, then we really wouldn't have a job. But what we see is you kind of get two scenarios. First of all, you mentioned they just don't know what the work demands are. Maybe the person in the room is giving them accurate detail, maybe they're not. And the other side is, for a long time, my doctor was my Sunday school teacher. So, when I'd go, and I would still be his patient, but he's too far away. But I'd go to him and he'd say, well, what do you want? And I'm like, and that's just the reality of it. So you need an independent person to do that. And so a lot of our employers have started to push. You meant, if there's a certain, and you also mentioned the situation where they had restrictions, permanent restrictions for years, and all of a sudden it just vanished, right? And so, like, how do you objectively, to your point, you're not aware of that ever happening. So some of our employers who are a little more advanced have actually set processes in place, and for the orthopedic groups, especially, and the specialists that work with them, like if you hit a certain criteria and there's a certain type of change or whatever the parameter is, it requires an FCE because the employer has seen that the other way doesn't work. And so we've helped them see that. but I think enlightening them to like, hey, we're only here about outcomes. And if the return to work outcomes are great for that current model and the way you're doing it, then great. And they're like, no, that's not why we'd be talking to you if that was the case. So I think that's where, as physical therapy, we can definitely push towards those functional testing. Specialists don't normally go looking for it, but if you get an employer that's willing to go out and kind of, especially in our state, because they can push a lot of work their way as well, then they can sometimes drive that. And sooner or later, the specialists get used to it. And they're like, oh, this is one of those, they got to have a referral for an FCE. So I love that you're doing that where you're at too, because that's what we've seen as a big gap is, and some of the physicians that resisted it, our discussion with them is like, it's not even fair to you to have you sit in a room with literally, yes, you got documentation, but no functional data, and to then make a restriction or a recommendation on the functional capability of that person just based on what you saw under surgery and under whatever the visuals for that were. And it's like, we're going to give you an extra set of data so that you can, verify what your your assumptions are. And sooner or later, they appreciate it. It may not be when you start, but sooner or later, they do understand that it helps them be better and it helps their outcomes too. So I just thought I'd add that.
Well, and I think if more physical therapists or occupational therapists, when they accept a referral for an FCE, ask the basic question, is the person still employed, and clarify that right up and offer to do the service at the work site. To me, it's a game changer to do it at the work site because we can both clarify the job demands and the person's abilities and engage them in a interactive response, which is really the essence of what the ADA does.
Yeah, I like that. Thank you.
And I saw you come off speaker at one point or you have a question? You're on mute.
Rick, you made a comment at the beginning about 6 visits or 12 visits or something like that versus 24. And I didn't hear the beginning part of that. You're saying that I thought I understood you to say if they are at the job site, it's less visits as compared to the actual clinic. Is that the point you were making?
Yes, the visits are typically a bit more intense because they're one-on-one and you have to spend a little bit more time per visit. But we get the job done. I mean, my average number of visits when I get a transitional work therapy referral is typically 6 visits from start to finish. And I think it's because I'm looking for opportunities to bring the job demands. I'm mediating some disputes and confusions with the employer, whereas it's very common in our workers' compensation system to see them in a clinic-based physical therapy program, then work hardening, then work conditioning. You can imagine how it all works with the whole hand therapy thing, where we start with them at a round table and all they're working on is their hands, and then someone wakes up and says, hey, the hand is connected to the whole body, and
Right.
and so they go from hand therapy to work conditioning or something like that, and during that whole process, no one is talking to the employer or clarifying those things, and that's the dysfunction in our part of it. And that's the advantage to having a presence at the work site. But if you don't have a presence at the work site, like in our CPG, the evidence for doing functional job descriptions is only like a grade C evidence, but it's because we haven't done the research to show just how valuable that is in terms of influencing the trajectory of care.